Good evening, everyone. Thank you for joining another TOTEM talk. I'm very happy to have back Hannah Conway for her fourth or fifth, I think, teaching with us. Starting to lose count now.
I'm a local.
So yeah, real pleasure to have you back again, Hannah, teaching us on something that we've not had any teaching on yet, which is focused TOE. So it's a new topic for everybody, or new topic for TOTEM. I mean, for some of you, it might be a very old topic. But without further ado, thank you so much, Hannah. I'll hand over to you.
Thank you, Samson. Well, it's really nice to see you all, virtually, albeit. And today is going to be, if anyone came to the FUSIC HD talk, whenever that was, seems like forever ago, it's going to take a similar format. But I appreciated not everyone today will have embarked on focused TOE. So I thought it'd be actually quite interesting to do a quick overview of the actual data set, so that if you're kind of on the edge about whether or not focused TOE would be something you'd want to do, and this could hopefully convince you that it's a worthy modality to pick up if you're sort of in an area that you think focused TOE would be available to you. So without further ado, let's go through the slides. If I can figure out how to use my, there we go. So in terms of our sort of general objectives, I want to go through the data set with you. I really want to get across to you how to kind of confidently document the structures, whether they're normal or abnormal. It is as important to recognise normal structures as it is to recognise pathology. And I also want you to be able to sort of report systematically. Certainly when I was learning echo, I found the reporting the most difficult part of it, actually, because you'd got through the however many scans you were doing, and then you had to sit down and kind of go through all of that again. So if you can find a systematic way of reporting, it will certainly pay dividends going forward. And then we'll finish off with a little bit of common reporting errors. And this is a bit of an insight for those of you who are doing focused TOE. Hopefully it will enable you to feel more confident when you're coming toward the exam part, because I'm going to share with you some of the more common reporting errors that we are seeing and how to avoid them, essentially, before you have to have a resubmission. So why does all of this matter? Well, it does matter, because it's not just about we're telling people off untidy handwriting, although it might feel that way some of the time. There are some technical details that we just need to go through. So the accreditation itself is a mark of, a national, international benchmark standard. So we need to ensure that you're at that standard, and it doesn't just stop and start with the quality of your images. You need to utilise all of that information that you've acquired through those images to be able to come out with some useful information to guide management. And, the person at the end of it is a patient, and, you need to be able to understand that the report itself is going to be the thing really that actually changes that needle. And if you haven't articulated yourself very well in the report through untidy handwriting or incomplete reporting, then you're going to lose all of that impact, or it's going to have a negative impact on the patient, which is obviously the opposite of what we want. And the other thing to consider with TOE is we're putting the patient through a higher risk. Transthoracic, we can pop a probe on with the confidence that we're not putting the patient under any form of risk, really. Certainly not from a sort of mechanical risk, but we are now doing that through the method of actually inserting a probe into the esophagus. So you really want to make sure that if you're taking that risk, that the benefit at the end of it has been able to outweigh that. Now, in terms of the report rejection, we'll go through this a bit more later, but the main things really that I want to get across to you is that if you can, document your report well and, articulate cardiac physiology and pathology, that is all that you need. You don't need to come up with all the fancy terminology at this stage. Being able to use just simple descriptors is sufficient at a basic level, which is where we are with focused TOE. And I suppose the final thing is to understand what your supervisor's expectations are. At very minimum, they should be aligned to what the focus data set is, but there might be supervisors that have slightly different expectations on what's required, and that's okay. You need to have that conversation with your supervisor. Bear in mind, most, in fact, all supervisors will have level 2 accreditation in TOE. It may be that they want to share with you slightly different ways of doing the data set in terms of order, and it may be that they want you to report in a slightly different format, although for the actual accreditation we'd expect you to use the template which we provide. Although that's not to say that your reports would be rejected if you've used a slightly different template. So that kind of conversation with your supervisor is really important to have at the beginning of the process, just so you know exactly where you sort of sit with the expectations. So in terms of the data set itself, there was a paper that came out when it was launched, which has all of the salient information to really kind of underlie why we developed Focus TOE in the first place. But really, it's just important to recognise that very rapidly after its launch, which was only a couple of years ago now, there's been quite a lot of enhancements made to Focus TOE. So some of the data that you might find out there, certainly some of the American data that underpinned the rationale to launch in the UK, it may be slightly different to the expectations, which is why it's really important to always refer back to the FUSIC Focus TOE data set. Now, I'm happy to say we have now got to the stage where we've made all of the data sets public open access on the ICS website. I know that that's been launched for FUSIC Heart and FUSIC Lung, and we're in the process of making that available for Focus TOE HD. So you don't have to register to get this information, which is really important because we want supervisors to know exactly what the expectations are from an examiner point of view. And if you're kind of wondering about whether or not to do this process, you can get that information before registering, so you know if it's something that's achievable for you. Having access to patients who are having perioperative TOEs, for example, is a major limitation. So have a little look first through some of the information that's available on the ICS website, and this particular article is freely accessible on JIX. If someone has issues downloading it, I can provide you a copy. Now, I created this as part of my education courses that I run, and the reason why we did this was because it's a quick and simple thing that you can probably just keep on your phone and flick out at the time in which you're doing an exam at the bedside, or better still, you can print it out and actually laminate it and just stick it on the side of the machine. And it's just a sort of very visual aid memoir on what views Focus TOE expects, because if you look at a more comprehensive TOE exam, there's about 40 plus images expected of you. So we're not expecting you to do that, and for the purposes of Focus TOE, we purely want you to look at 8 individual views. Now, with those views, you might have to do additional colour Doppler. So if you sort of look at your scan when you've ended, you'll end up probably with about 15 images overall. But there are only actually 8 views that we expect you to achieve, and this will be something that you'll be expected to simulate on the exam. But as you can see, we've got mostly mid-esophageal images, so everything on the top 2 rows are mid-esophageal, and then we finally go into the belly just in the transgastric level to have a look at the left ventricle in its short axis. We don't go into a deeper level because of the associated risks of perforation. And then on the way out, you can then look at the descending thoracic aorta. So it's a really simple scan to perform, and actually it can be performed in about sort of 12 to 15 minutes, providing there's not extensive pathology that you need to spend a bit more time on. So we're going to go through these views just so you know what's expected and what's normal first, and then we'll move on to reporting pathology. So the first image that you're going to obtain once the TOE probe is in, and we're not going to focus too much on the insertion and whatnot of that because it's outside of the scope, But the first image that we're going to expect you to perform is in the mid-esophageal layer, and that will be around about 30 to 40 centimeters depth. And helpfully on the TOE probes, you'll see markers so you can sort of determine where you're meant to be. On the multi-angle adjust, you want to be between 0 degrees and 20 degrees. And as you can see here on the HeartWorks simulator, you can see it's essentially creating an upside down apical 4-chamber window, which you'll all be familiar with. So the right heart is on the left and the left heart's on the right. And the first thing you'll notice is that the quality should be far superior to that of your transthoracic. So what are we supposed to be looking at? Well, again, you know, if you're familiar to looking at transthoracic echo, this won't be too difficult, except you just got to remember everything is upside down. So left heart on the right, and you can obviously see left atrium, mitral valve, left ventricle. And it's really important, just like when you're doing FUSIC HD, to start looking at the walls in the 16-segment model rather than using a very basic 4-segment model. So your anterolateral wall, infraseptal wall, and then your RV3 wall. Note how you can't really see the full volume of the atria, and that's a real sort of drawback to transesophageal imaging, just because of the proximity of the atria to your probe. So it's not the best actually for assessing left atrial, and certainly not right atrial size. So don't worry too much about that. And most people will have had a transthoracic echo, or at least an attempted transthoracic echo, before they've upstaged that to a TOE. So you should be able to at least make some inferences on size. So what's the assessment? Well, most of what we're doing in the 4-chamber is eyeball, okay? We're not going to be doing any ejection fraction or anything like that for focused TOE anyway. So we're expecting you to use your trained eye, which by now that you should all be very confident doing, and utilize that kind of, you know, moderate, severe, or significant, whichever terminology you want to use. Is completely reasonable at this stage to use binary categories of severity. But I would probably argue that if you're at the level now that you're doing focused TOE, you should start to utilize the terminology that's more synonymous with advanced accreditation. RV size and function is mostly by eye, although we do measure the RV dimensions, which I'll show you how to do that in a moment. Atrial size, I've talked about that being a slight drawback, and we can see the tricuspid and mitral here, which if we wanted to have a really good look at, we could obviously reduce our depth and have a really good look. I think the benefit with particularly mitral is that because of the resolution, we can actually make out potential pathology that's confined to a scallop, although we're certainly not expecting you to start identifying which is P1, P2, P3, but it is very helpful in certain pathologies such as prolapse, if you're able to identify if there's a prolapse of the central scallop versus lateral. RV dimensions, very easy to do and very similar to that of HD. So inner edge to inner edge, end diastole. And as you can see here, I've just pulled off the European guidelines, which is pretty much the same. And as you can see, it's very clear what's expected of you. So moving on to the 2-chamber, 30 to 40 centimeters. So all you're needing to do now is change the angle from 20 degrees potentially to 90. And what you've done is isolated the left heart. This is really good if you're worried about regional wall motion abnormalities, because you can identify if the anterior or inferior wall is affected. Again, left atrial size is a slight question mark given the you know, the issue of the atria being too proximal to the probe. And again, mitral pathology, very important, because we've got an orthogonal view now of the mitral valve. Whereas we've seen it in the 4-chamber, we can now see it in 2-chamber and get a really good sort of 3D sort of view of that 2D structure. And if you do slightly reduce the angle on your omniplane, you can actually identify the left atrial appendage. Now you can see that our angle adjust has been adjusted now to 64. Something between 60 and 90, you'll find a nice view of your left atria. And really this is something that you'd want to look at in most cases. I think it's important to do that, but specifically in patients that you're that are known to have AF, potentially acute and even chronic. And here you can see a patient with a large clot in their left atrium. The 3-chamber, we're not moving the probe, it's staying exactly where it is, the depth is the same, and again we're just putting more angle on, so we're around about 110, 140, and we're doing a cross section now through the left ventricle and the aorta. So this is very similar to a parasternal long axis view, and the benefit to this view is that we can assess not only the anteroseptal infralateral wall, which until now we haven't seen, but we can actually see the relationship between the mitral valve and the aortic valve. So very helpful when it comes to assessing for LVOT obstruction and SAM. Okay, so these are things that I would urge you to look at and comment on, specifically in patients who have got high risk factors. You've also got a really good view of the proximal aorta, which is important when you're considering dilatation and dissection. And that's pretty much it for this view. You've got a little view here of the right ventricle, but it's obviously only a slight section of it, so we can't really comment too much. If we were to pull the probe back slightly, then we would and reduce the angle ever so minimally, what we will be able to do is see a really good view of the ascending aorta rather than just the proximal route. We want a good sort of long axis of the aorta, and the benefit here is that we can now measure all of those aortic dimensions. For those of you who are used to doing focused FUSIC HD, you'll know how important it is to correlate your eyeball findings with measurements. So you've got your annulus, your sinuses of Valsalva, you've got your sinus tubular junction, and then finally you've got your ascending. And the marker of knowing that you are where you need to be is that you can also see a cross section of the right pulmonary artery just sitting above the ascending. Now, in terms of the actual dimensions, again, I've pulled this off the European guidelines, but if anyone's got the EchoCalc app, then they will also be present on there. And I'm a lover of technology and having things in a mobile fashion. So just being able to pull that out and being able to correlate your measurements with these numbers is really helpful. So those are the sort of expected values there. We bring the angle back now. So if you're someone like me that sort of has to think about things visually, you've took the angle right the way up to 130 for the long axis, and now you're coming all the way back before you go into the stomach. Okay, so that's the way I've always ordered my scan, because I don't want to be going back and forth or having to go in and out with the probe. So now I'm back to about 90 to 100. And if I want to see a right-sided structure, then you always roll clockwise. Okay, no matter where you're standing, it will always be a clockwise roll. If you want to see more left heart structures, you always do an anti-clockwise roll. So the benefit behind doing bicaval is because well, there's multiple reasons why we look at the bicaval view. Very helpful for those of you who do ECMO, because if you haven't got an image intensifier in theatre, then it might be that you need to place your VV ECMO cannulas under TOE guidance. And obviously you've got your IVC and your SVC, and you can see the return, the return port going just over the right atrium. The intraatrial septum position, really important. We know that because we can determine whether or not there's pressure increase in either side of the heart. That's a really simple way to assess for that. And because we're using colour, we can also look for any signs of shunt. So even if it's a simple PFO or something more significant like an ASD. And in addition to ECMO cannulas, there are other things that we know sit in the right atrium. and one of those will be PA catheters. If you're worried about, trying to go around in circles with your PA catheter, certainly I think TOE or transthoracic guidance can help determine where you are in the heart. And obviously you can also determine where your wire is just before you dilate, for example. So these are all useful things to think about when you're performing TOE. Bring the angle back a little bit further and you're going to be at the RV inflow outflow view. I love this view. It's essentially the parasternal short axis aortic level view in TOE world. I tend to call it the wraparound view, owing to the fact that the right ventricle wraps around the bottom of the image. And if I was stuck with PA catheter, not knowing exactly what's happening, and they are certain things that just go in first time or you're there forever, the catheter becomes soft and it keeps going round and round in the right atrium or the right ventricle. And to prevent you from sort of going blind, you can use this view quite nicely because you can see the whole of the trajectory of your PA catheter. In absence of that, it's obviously very helpful for other things. So the right ventricle can be looked at pretty much in its complete sort of structural form, even though we can't really see the whole of the right ventricle in any one view. This is probably the best view to look at the right ventricle because we can see the inflow and the outflow. We can look at the tricuspid valve and we can also look at the pulmonary valve. Bearing in mind, the reason why we didn't include that on the report, you might be asking, is because unless you've got pulmonary regurgitation secondary to pulmonary hypertension, structurally, there's not that many things that are wrong with the pulmonary valve in the normal adult population. You'll normally know about somebody's pulmonary valve dysfunction ahead of time because that'll be a grown-up congenital, for example. So it's unusual unless obviously there's extensive endocarditis. But that's the reason why, because most pathology that we're going to want you to identify will be confined to the left-sided valves and then obviously tricuspid valve, usually because of either endocarditis or functional TR. The other thing is we've got a really nice sort of on-fast view of the aortic valve, so we can have a really good look at the morphology. We can have a good look at whether or not there's any restriction, calcification, obvious stenosis. And for me, putting colour on top of the aortic valve, if you have previously identified some aortic regurgitation, I think it's really helpful because you can check where the origin of the jet. So very broadly speaking, if it's central, then there might be some sort of functional etiology, i.e. the annulus is dilated out, and then you can start interrogating the aorta a little bit more effectively. Or if it's, if it's eccentric or it's originating between the commissures, it's often degenerative and it's something that has affected that particular cusp. So these are the things that I would be looking for when I'm putting colour on top of the on-fast aortic valve. And then again, we've got a nice view of our intra-atrial septum, just to give us some indication of volume, pressure on either side of the heart. So we talked about most of that already. There's nothing else, I don't think. In terms of eyeballing RV size, it's important to recognise that this isn't the greatest view to assess RV size, purely because it's it's a wraparound view. But I think it's important to measure or eyeball in every view you see. But when it comes to internal diameters, do try and confine that to the apical forechamber. And at this point, when I'm teaching people how to do focused TOE, I always say take a breath at this point, because you're now going to be going from the mid-esophageal depth into the actual stomach to look at the mid-papillary transgastric level. And at this point, this is where most of the actual perforations take place. So the important thing is to make sure that you've took off all of your degrees and that you've took off any flexion of your probe, even though this appears like there's flexion here. This will be the position in which your flex will look when you're looking through the ventricle. But as you're advancing to this view, you need to make sure that your probe is completely straight, and then advance without force. going through the GOJ, and then eventually when you're around about 45 centimeters deep, you can then start to gently anti-flex, and what that will do is provide you a cross section of the left ventricle, which looks obviously very much like your parasternal short axis window. And before I move on to what we assess, really helpful, because we don't often think about the right ventricle. I think I've probably gone on about that a bit too much, but do make the effort to do a little bit of a clockwise roll at this stage, because you can then move the whole ultrasound beam over to the right side of the heart to really give that right ventricle a good look at, especially if up until this point you've been worried about the size or the function. Rolling back now anti-clockwise, you'll put the LV in the middle of the image, and here all you need to remember is that all of your wall segments no longer apply. If you've learned them for FUSIC HD, you have to think again, because it's obviously they're all in a slightly different place, i.e. upside down. So the first thing, if you guys are getting used to trying to remember your wall segments, just make it easy for yourself. First of all, go back to a 4-segment model and use the first wall that you definitively know is the septal wall, because it obviously separates the left and the right ventricle. Opposite that septal wall will be a lateral wall. The probe is closest to the inferior wall, so that will be your inferior, and then opposite to that will be your anterior. So we've got 4 segments. The only thing we now need to do to make that 6th segment is just separate your septal and lateral wall into their respective inferior and anterior segments. So this then becomes your infraseptal wall, anteroseptal wall, anterolateral wall, infralateral. Okay, that doesn't necessarily work for everybody, but personally that worked for me. It kind of got me out of that worry, especially because I was learning transthoracic and TOE at the same time, so it was a complete nightmare, but that's a really good way to remember it. So what are the things that we want to assess? So yes, we eyeball the function, because I still maintain in a critical care setting where you want the answer now, it's very easy and probably more reliable for you to eyeball the function. You've seen plenty of ventricles by this point, and I think it gives you more valuable information than just trying to come up with sort of fantastic ways of assessing it without having to use the proper tool, which is obviously Simpson's biplane. But we do actually use our M mode or 2D calipers to measure the internal diameter here. So that's something you can do, and it will give you, if you use M mode, an ejection fraction. It will also give you fractional shortening. I'm not suggesting that they're inferior to other methods, but it's important to recognize you're only looking at one line through the left ventricle, and therefore you have to make sure that you've not got any significant regional wall motion abnormalities when you're performing this. And just to show you where you'd measure, you can do a 2D assessment here in obviously end-diastole to get your internal diameter, or if you want to get that additional information like Tyke holes, ejection fraction and fractional shortening, then you would have to use M mode, which will give you a dynamic assessment, and that will be something which, again, it's not necessarily a minimum requirement, because if you just eyeballed the function, that would be fine, but we are moving to the point where most people are happy to not only give the eyeball assessment, but to use these very basic tools of ejection fraction, just to kind of sometimes help them decide whether their eyeball assessment is accurate. And the final view, as we come out, I always do this view on the way out. Some people do it on the way in, okay? And this is the descending thoracic aorta in short axis, okay? And because it's a left-sided structure, we roll anti-clockwise. And this, as you can see and appreciate, which is why we love TOE for aortic scanning, because the resolution is unparalleled. Although I haven't reduced the depth here, which is very naughty. You'd want to reduce that depth to increase your frame rate. As you can see here, it's very, very nice image where you can actually see the layers of the aorta, and it would be very easy to determine if there was any atheroma, for example. Other things that we want to look for, thrombus in those rare cases, but obviously dissection is one of our main indications for doing a transesophageal echo. And also, if we see any collection around this particular structure, then it is going to be our left pleural effusion as opposed to our right, and I'll show you a little tip as how to remember that. We can also use it to guide IABP, and it's not as simple as detecting the wire in the middle of the aorta. We have to pull out ever so gently until we start to see the left subclavian artery start to branch off here. And if you can still see the actual wire in the aorta at that point, you know that the wire is too high. So you'd ask them to pull that down. Okay, that's how we guide IABP insertion. I'll talk to you a little bit about left pleural versus right pleural. Obviously, this patient's got a dissection. The reason I know this is left pleural is because A, it's got the descending thoracic aorta in the view. You wouldn't see the aorta with a right pleural effusion. And B, we call this the tiger claw, which is probably quite clear to see on this little schematic. As you can see here, the claw is facing to the left, and that's always indicative of a left pleural effusion. And if the claw points to the right, then it's a right pleural effusion. But bearing in mind, you won't see the aorta in that view. So that's a nice way of checking your pleuras with your TOE probe. So focused TOE views done. That's hopefully a nice refresher for those who are doing it, but also for those who might be viewing it for the first time. That's what's expected of you for focused TOE. So the second part of this, in the time we've got left, I'm going to hand it over to you. I've prepared a case which is quite interesting, actually. And, I know it's not always people's cups of tea to get involved, but there's quite a small group of us. So do get involved because it'll test your interpretation. I want to just, first of all, introduce you to the logbook report form. It's been designed to be quite simple, although it's not the finished product. There are certainly things that need to be done to improve on it, but this is what we, certainly not me, Antonio Rubino came up with this iteration, and I think it served the first few candidates that have been through the process really well. It's took away that kind of burden of having to remember lots of numbers, and it's made it quite simple. As you can see here, most of it is sort of binary, although there is some requirement for you to put descriptors in. Very recently, I've just provided an exemplar report, which I think should now be uploaded to the newest accreditation pack. And I just wanted to use a normal study because the expectation is that you still need to report normal findings, which is something, unfortunately, that hasn't shown through on some of the exam candidates that we've seen. And obviously it's up to us to provide that guidance. So in a normal study, the expectation would be for you to obviously do the circling of normal, but also to use descriptors. So for example, here we've got right ventricular function. You could put normal, but actually it'd be really important to say why you've come up with that assessment. Well, you can do TAPSE with transesophageal echo. It's slightly different the way that we do it. But if you have performed it, what does the TAPSE measure at? Also commenting on the radial function. So you've got a complete sort of assessment of the ventricle. For example, the ventricular cavity size, you might say it's normal, and it might be, written very clearly on your scan. But as examiners, we need to know what you measured it at so we can correlate those findings. So always put measurements next to your findings so that we can go back and have a look if they match that particular category. So in terms of the mini case study, let's have a look at this. Right, so this patient, 65, 88 kilograms, emergency type A dissection, and basically pre-bypass this patient kept having sort of dynamic hypotension, and the patient had been sort of rushed through with a very poor CT, and at that time there was no evidence of collection. There was some evidence of thrombus around the aorta, but there was certainly no evidence of tamponade, and our concern was that the patient was tamponading, which would obviously cause a slight concern in terms of getting the patient operated on quicker. The patient's on labetalol, we've identified exactly what mils per hour they're on and written down the hemodynamics. Things like this often are missed, and it's important that you try and make sure prior to submitting your reports for your exam that you've included all of this clinical context, because it does have a massive impact on your findings. And obviously really, really important things are, we need to see that you've had, if you've had difficulty, please write information about that. Complications, if there has been any, again, do be transparent about that. This is an intraoperative scan. So, I mean, rather than me explain it to you, it'd be really interesting to have you guys sort of talk about what you see. I don't know if anyone wants to put themselves forward. I don't bite, nor does Samson. What I will say is that this is meant to be a mid-esophageal 4-chamber view. Anything sort of look abnormal?
I'll volunteer myself to break the silence, although I have very limited skills in TOE. So the LV looks like it's squeezing pretty well from this view. The axis of which the aorta seems to be leaving looks a little bit different to the esophageal 4-chamber you showed earlier. You can clearly see the dissection flap inside the aortic outflow, and the mitral valve leaflet that is close to the aorta seems to be obstructing the outflow tract with ejection, and the RV looks impaired from what we can see, but it's obscured by the aorta.
Brilliant. Well, I couldn't have asked for more. Thank you, Samson. I mean, it's a different modality, but the principles of interpretation are pretty much the same. So the first thing to note is that the aorta is obviously, we know the pathology, but it's important to also recognise that what sometimes is seen on CT is slightly different to what you see on transesophageal echo, and the surgeon does hold a lot of weight behind what the TOE says prior to bypass. So that conversation will happen between, you know, gas man and surgeon as to primarily where the extension of the flap originates from. They're really concerned about that, if the actual aortic valve has been affected, and if there's any regional wall motion abnormality because the flap has gone down to the coronary ostia. So the first thing you said was that the LV looks like it's pumping pretty well, which is good, because already we've kind of, even though we haven't looked at the full scan, we've kind of alleviated one major concern, which was that we've completely knocked off our coronary supply. So that's sort of one less thing to worry about. We've identified the flap. The fact that the aorta is right in the middle of the image is due to the fact that it's obviously dilated and dissected. You correctly said that the right heart is pretty much obscured by the dilated aorta, which is important because we can't always see structures because of one reason or the other. So try not to kind of overreach, and always explain if you can't see something, then you can't assess it, and that's really important to do. Other things that you spoke about were the mitral valve leaflet potentially obstructing the outflow tract, And that's important to recognise, to train your eye to that. But there's a few steps that we need to perform in order to identify whether there's true obstruction there. Other things to suggest is that, I don't know if any of you can see, but there's a little bit of spontaneous echocardiographic contrast in the left atrium, which would potentially signify that we've got a little bit of turbulent flow in this instance. Okay, but overall, spot on. Let me go around to our two-chamber view now. So we've got our anterior wall and we've got our inferior wall, and we've obviously got our mitral valve. Remember your leaflets that we need to identify which are which. We've got our anterior leaflet and our posterior leaflet. So it was the anterior leaflet that Sampson was concerned about in terms of its sort of general movement toward the LVOT, and it'd be important for you to comment on the leaflet structurally. So does anyone want to sort of make any commentary on the leaflet? Remembering that the basics of valve assessment at this level are, if you can see the morphology of it in the instance of the aortic valve, you'd comment on that. But really, it's about if it's thin or thick, if it's mobile or restricted, and if there's any obvious calcification. Okay, so looking at this mitral valve, would anyone want to sort of comment on how to report that? Everyone's scared. So let me have a try. So without comparing it directly to another valve, it can be quite difficult actually to determine if something's thick. So a 4-chamber window is quite helpful. So, you know, let's go back and have a look. Well, in this instance, it's not very helpful, is it? Because we can't see our tricuspid valve. But you can see a little bit of it here, and it's very thin and mobile. But if we look here, I would argue that the leaflets are a bit thickened, very mildly. And in this instance, the actual mitral valve leaflet on the anterior leaflet is slightly longer than I would expect. The coaptation is not normal from what I can see. You don't have to do fancy measurements. That's for someone else to do. But at this level, you can describe grossly and descriptively what you think might be wrong to the appearance of that. And I think that would be sufficient. If we go around to our 3-chamber window, we're looking at the mitral valve now from all sides, and it's really important to track that pathology through. So the anterior leaflet here, again, I'm convinced now that the actual leaflet is mildly thickened, having looked at it from all sort of angles, and it's either structurally long or it's the fact that the motion of it is obviously pulling it down into the LVOT. Okay, we can't really definitively make that decision unless we do an actual measurement of the anterior mitral leaflet. There are measurements for that. They're quite complex, and we wouldn't expect you to do it at this level. But in any case, we've recognized that motion is abnormal. Okay. In terms of determining whether or not it truly obstructs during systole, simply we could just not do that. We could freeze the actual loop and we can watch. It will be quite difficult to understand this because we've got also a dissected aortic valve, where therefore we can't really see the aortic valve fully open. But I would probably argue at this point it's open, and we've got pretty much an obstruction to our LVOT here. We've now put some colour flow on. So how do we describe colour flow? So same as FUSIC HD, really. We're not expected to do very fancy measurements, but we should at least be able to identify the amount of the atria or the other chamber in which it's filling, how much of that it's filling. For example, in very severe MR, you would expect there to be over 60% of the chamber full from the left atrium. And you'd also talk about the direction of the jet. Okay, so in this particular instance, is this jet central or is it eccentric? Well, it's eccentric because you can see it tracking all the way through here. Now, arguably, when you've got something like what we call a wall hugging jet, then it always fits into the severe category. But here, as this was part of a more advanced echo, this was actually a moderate jet. Other things we can do is we can freeze the image and we can measure the width of the jet as it goes through the orifice, and over a certain value, I think 0.7, it would be regarded as being severe. This actually measured at 0.6, just for your information. Now, important to start tying in the things, we're worried about alveolar obstruction and SAM. So does this fit into that kind of etiology? So we've got an anterior leaflet that's being pulled down into the LVOT. You would expect the jet to be posteriorly directed. So all of this so far fits. The other thing to comment on is the colour flow pattern in the LVOT. As you can see, we've got a similar turbulence to what we're seeing in the MR jet in the LVOT. So we've definitely got some dynamic obstruction here. And it follows on into the root, but there's not to the degree that we're seeing it in the LVOT. So far, everything is showing me that this is alveolar obstruction with SAM. So now we can focus on our aorta. Obviously, again, as I said before, we can get a lot more helpful guidance off TOE sometimes than what we get from a poor quality CT that's been taken in an emergency. So as we can see here, we've got aorta, and here we've got our annulus, and the sinuses of Valsalva here. So really just above the root is the origin of the flap. And that's really helpful. And that will explain why we've still got very preserved LV function, which is the only thankful thing that this patient had to be thankful for. The other thing to note is here, look, that's quite thick there and irregular. And this actually turned out to be a periaortic thrombus. So this patient had actually bled and dissected quite a way before it presented. And as you can see, we've got sort of intramural bleeding there. And we've got our false lumen here and our true lumen here. And if we pull the probe back, we can see that flap extending all the way up the ascending aorta. Bicable view wasn't very easy on this individual. And by this point, we're sort of starting to get the patient on bypass. So you often find the last few scans will be a bit rushed. But important to identify any other pathologies that you might see. But from what you can see, the intraatrial septum is intact. And you can see a little bit of the line coming down from the SVC into the right atrium. RV inflow outflow view, really important. Morphology, particularly when you know the patient's had a dissection, is it because morphologically they've got a bicuspid valve with a coexistent dilatation? Is this patient going to need a valve replacement at the same time as having a root replacement? And actually, this patient had an intact valve trileaflet and actually didn't require a valve replacement, which is obviously better for the patient. And you can see now very clearly where that thrombus is around the cusps. Now, if you're obviously used to doing transthoracic, then you have to remember your cusps are in a different position. So here is our right heart, left heart is here, and your non-coronary cusp is here. So Nikki loves Ricky rather than Ricky loves Nancy. Okay, so again, these are little things just to remember. when you're transitioning from transthoracic to transesophageal. And then finally, going into the belly, we've been able to now get a good look at our heart. Any commentary on the ventricular sort of size function? We are a shy group.
The LV function looks pretty good from this view, hyperdynamic even. It's not quite kissing ventricle, but almost. Papillary muscles are touching. And there's no obvious regional wall motion abnormality that I can see from here. And the septum, you can't really see the RV that well, so I wouldn't really want to comment too much, but
yeah,
look, it doesn't look too flattened. Looks reasonably okay shape.
Yep, agreed. And even though we did actually measure it, and but if you look here, these are obviously centimetre markings. That wall is very thick. It's thick all the way around. But if we were to flick back to our, dare I do it, if we flick back to our views where we're assessing for SAM, this septal hypertrophy is part of the issue, that sort of triad of risk factors for SAM. So whilst we've got LVH, we've also got a specific sort of knuckle of basal septal hypertrophy. And that's really important because, again, it fits into the overall picture. We've got a patient with LVH known to have hypertension, risk factors for dissection, and now they've experienced a dynamic alveolar obstruction perioperatively. So when you go through your scan, you're answering the clinical question rather than just picking up numbers and figures and trying to populate a report. You're populating a clinical picture and figuring out what exactly is wrong here. And obviously the sort of best images tend to come at the end when you're pulling out the aorta here. You can see that flap very obviously. And an interesting one just to show you, it's very common to have sort of perforators along the actual false lumen or true false lumen interface, and this kind of jet here is just representing one of those perforations, obviously from the true lumen into the false lumen. So if you ever see that, that's what it is. Some people have asked that in the past, what is that? So when it comes to then the report, by this point you shouldn't be having to kind of reset your brain. You should already have kind of talked through what you've seen, so much so that yes, you have to write down some numbers, but you've got a story to tell. And once you get to that level of confidence with reporting, you'll find it actually, it's a lot less taxing than it has probably been up until this point. So LV size was essentially normal. The LVID was about 5 centimeters. In systole, it was reduced. And you know, that was most likely due to the fact that they had concentric LVH, but also that they were vasodilated because they were obviously anaesthetized. That's really no bearing. The fact is, in their internal diameter in diastole, that was pretty normal. I commented additionally on the fact they had moderate LVH, which if you want to measure the walls, that would be completely reasonable because it's not too much of a stretch from doing your internal diameters. Or you can just use the basic sort of visual assessment. And I've also specifically talked about it being particular at the basal septum, which is very important because obviously that then starts to build that picture of risk factor for SAM. Then we've got our function, which was essentially normal, estimated visually over 55. If you're happy with it being normal, then you can just use that range. Okay, you don't have to guess a fraction or a percentage because we don't have robotic eyes. But if you think it falls into the normal category, you can write it is over 55%, as we know that is a normal range. It's really important with patients who've got a dissection to comment on whether or not there's obvious regional wall motion abnormality. If you don't see one, Always document it, because that's really important. Okay, right ventricular size was normal. A bit naughty that I didn't document the size, but actually in this instance wasn't able to see it very clearly. But if you have an opportunity to do so, always make sure that you include the dimensions. And the right ventricular function, from what I could see, was normal. Mitral valve structure was abnormal in the fact that it was mildly thickened, which is not normal. And the leaflets, albeit they were mild and no calcification, I did feel, and actually we did measure it afterwards, that the mitral valve leaflet anteriorly was quite long. And this obviously created that sort of vicious circumstance of LVOT obstruction and SAM. I've talked about it resulting in significant eccentric MR, which is directed posteriorly. Okay, that's the level of description that we'd expect of you. Aortic structure, the valve itself was normal, which is important, because immediately you'd be like, that's abnormal. But that is, most of the aorta was abnormal, but the actual valve leaflet itself was pretty normal. It was tri-leaflet and there was no obvious calcification. It was unrestricted. And the function itself was also normal. There was some mild AR, but I don't think that is in the kind of world of focused echo, that I think would be something that you would be happy to write down as being normal in the circumstance, but always make sure that you write some descriptions about where it originates from and what direction in which it's going. The aorta itself clearly was one of the major abnormalities. We know it's a dissection. Obviously, the report form talks about possible dissection, but we can also write down some more information here. It's an extensive flap. It extends from just above the root right the way down to the descending thoracic aorta, and there's a periaortic clot surrounding the aortic root. And you can also give some dimensions as well. These are really helpful because the surgeon will usually size up graphs based on some of your TOE measurements. Tricuspid valve, from what we could see, was normal and had normal function, although we measured it in some of the views to have central TR, but that's what I would regard as being physiological. And then as we move down the report, really important in the instance of a dissection, to identify if there's any coexistent pericardial effusion. Not usual if the flap is above the root, but you would often see it if it's gone further proximally. But in this instance, we couldn't see anything. I think I probably saw a tiny little sliver around the left heart and the right heart in the forechamber, and that's important just to comment on. Also making sure that you identify if there's been any collapse of the chambers. And finally, if there's any obvious pleural effusion. So in terms of how you summarize that, you know, you don't have to use exactly how I report, but personally, I like to report for the reader. So if someone else is going to be reading this, they may not be familiar with TOE. So I try and make it as descriptive and narrative as possible. So it's just very clear, just a handover on ward rounds or on a handover as to what's gone on. So we know there's dissection flap. It arises from above the aortic root, extensive clot surrounding the root, extending beyond the limitations of TOE visualization, trivial pericardial effusion, no chamber collapse. In addition, the combination of significant LVH and basal septal hypertrophy and the long anterior mitral valve leaflet has resulted in LVOT obstruction and SAM, and significant eccentric MR causing severe dynamic hypertension. So whilst it might look a bit wordy, what I've done is I've given all the really key information that the surgeon might need and that people post-operatively would want to know. But also I've answered my clinical question, which was, why is this patient having dynamic hypertension? Is there a pericardial effusion with tamponade? And I've identified that that's not the case. And I've given a reason as to why that might be happening. So in terms of changes in management, this is what separates us apart from other clinicians who do echo, because we're managing the patient clinically. So you can then start to make some management decisions. And obviously we know how to manage SAM. slightly different in this patient because we don't want to push their SVR up, but just give a little bit of a sort of general idea about what you think's right to do with this patient. So just to finish off, common pitfalls with echo or focused TOE, and I'm tailoring this to what we've seen in the exam. So incomplete reporting. It's not to say that you will get every single view, but you should get most views with transesophageal. Okay, so make sure you do your 8 windows, and even if in the very first image, like we have identified the main pathology, you always have to report all of those 8 views to make sure that you've got a comprehensive assessment of the pathology. Don't use any vague pathology, and what I mean by that is, rather than sort of hedging your bets and saying there's a possible effusion, with the level of detail that you get with TOE, you really should be saying yes there is, or no there isn't. And I think that's fair to say. So, you know, utilizing something like small circumferential pericardial effusion without any chamber collapse would be more appropriate at this level and with this tool. When it comes to missing measurements, not really acceptable. If we're popping a probe down somebody, increasing their risk, we need to make sure that we've collected as much information from that patient as we feasibly can within the scope of focused TOE. So it's not really acceptable just to circle normal, normal, normal and not provide measurements, especially if it's abnormal, which we've also seen. So please make sure that you always place measurements, ejection fractions, anything that you've collected in your report, so we can see if they correlate. Another thing is overreaching conclusions. It's very, I do feel for a lot of you, because a lot of you are learning focused TOE potentially as a stepping stone for more advanced echo, and therefore it can be really difficult to separate what's focused TOE from the more advanced echo that you're learning in parallel. But it's really important for us as examiners to make sure that you know the scope of focused TOE. So you have to get to maybe, you know, report as you would normally report on the more advanced template, but then make sure that you only take away the information from the focus scan and put that on a separate report, okay? Because it's a really, really quick way for us who don't know, you know, you from Adam, and take you at face value and see that you're reporting on things that shouldn't really be, you know, like PISAs and things like that. You know, we need to know that you can work within those confines. So often we do see people that have 2 logbooks. They have a more advanced logbook and they have their focused TOE logbook. And then I suppose the last thing is you must be able to answer the clinical question. So the first thing is there must be a clinical question. You can't just say, oh, this is a training scan. There always has to be a reason why you're doing it. And certainly when you're doing it outside of your accreditation, you have to rationalize and justify why you're doing a TOE. It can't just be as simple as LVRV function assessment, because arguably you could do that with transthoracic. So why have you chosen to do a TOE on this patient? Okay, and that will then kind of lay the foundation for your report then, because everything you're doing is to answer that question, and that's what we want to see on your reports when we're examining them. And I think what I'd sort of said earlier is kind of summarised in this one slide, with the most important thing being that you need to integrate across the scan. So it's important not just to make one decision based on one view. Even though TOE's got far superior resolution, you still need to correlate your findings across different views. You always need to apply clinical context. I know that it must feel like we're constantly hammering this into people, but that's what I think separates critical care and physicians and practitioners from individuals that perform echo in a departmental setting. We're using this tool to change management, so it's crucial that we create a report which is contextualized to the patient's situation. I've talked about the report needing to be written for the reader rather than just being a tick box exercise. You know, it's important to collect the data, but make sure that you recognize that this is going to be read by several more people over the course of that shift, and then, you know, beyond. And we always need to be aware that, particularly because there was a recent coroner's case about transthoracic echo and something significant being missed on it. If you're doing a TOE on somebody, you want to bet your bottom dollar that it's completely reported to the max so that you can protect yourself medical legally, let alone do the right thing by the patient. So those are things that you need to just be aware of with the current climate that we're seeing. Serial assessment value, well, that just means, pay forward. You're doing a scan, but somebody else might need to look back at that scan later on in the afternoon or the next day to see whether or not that management strategy is working and whether or not they need to switch it up. So make sure that you're doing serial assessment on things that need serial assessment so that you can see a trend. I think I've hammered the thing home about focused echo being different, but one thing I think is important is that focused echo doesn't mean it's incomplete. You can still do a comprehensive scan in the sense of the word comprehensive. It's just not an extended data set, but it's still complete and it can still answer the questions that we need it to answer. And I think negative findings, what I mean by that is that it's important to report normal findings, okay? Because you're going to have a high proportion of normal scans in your logbook, not excessively, but you still will. And we as examiners need to know that what measurements correlate with normal. So that's important to consider when you're getting your logbook ready for examination. And that's kind of, for me, the kind of summary of what I'd want you to take away from today in terms of reporting. And in addition to that, I've just left some little resources here just for you. Obviously, one of them is going to be the actual training pack, which you should refer back to. It's been updated. There's an exemplar report in there now, hopefully. Other things that I think are really helpful is that we always refer back to the minimum data set for UK or for Europe. It's tailored to an advanced data set, but the numbers are the same, okay? So download the minimum data set for TOE, which is, I think, the 2015 version. And that's got a really nice sort of view-by-view breakdown about what measurements are expected and what assessment is expected in each view. And all you need to do is take away the bits that fall into the focused TOE data set. I think that's a really good sort of fallback. The EchoCalc app, if you haven't already downloaded that, make sure you do. And just to refer back to some of the things that we might not have covered, for example, when I did the talk on FUSIC HD studies, I put a section at the end on technical difficulties that you might have with the scan and how to report them. It's not going to be something you come across very often with focused TOE because there aren't as many technical difficulties, but there are instances where you can't get good images. That particular talk, which is on the TOTEM YouTube page, has got some sort of examples. And another thing, if you haven't already been told about this website, please get on it. It's Toronto General Hospital virtual TOE sort of software. It's free, and basically you can just go through a scan virtually. I found it really helpful when I was learning TOE.